Welcome to this week's Echo Diabetes in the Time of COVID-19 webinar session. We're grateful for the unrestricted educational grants that we received from Novo Nordisk and Pfizer Inc. that make this program possible. Our goal is to address the urgent needs of patients with type 1 diabetes and type 2 diabetes who will require complex diabetes treatment in the time of COVID-19 and beyond. We want to empower primary care providers and clinics to safely and effectively manage underserved patients who do not have access to routine specialty care. Even before COVID-19 pandemic, outcomes for patients with diabetes were suboptimal. Despite more than 25 years under recommendations for tight control, type 1 and type 2 diabetes, the majority of individuals with diabetes in the U.S. have been unable to achieve these goals. Data from over 190 million people enrolled in health plans that report HEDIS results to the National Committee on Quality Assurance illustrate system failure for patients with diabetes. In 2018, less than 1/3 of patients with type 1 and type 2 diabetes had A1C values at target, or less than 7%. Even more concerning, 30 to 40% of patients had A1C values greater than 9% or in poor control. We must recognize that these outcomes do not reflect non-compliance, but rather system failure. Minimizing hyperglycemia is paramount to reducing diabetes patient risks and vulnerability to infection and complications, including COVID-19. Now is an opportune time to overcome therapeutic inertia and make meaningful system changes so that people with diabetes are able to obtain glycemic control. We're living in unprecedented times with COVID-19, but systemic racism and health inequalities have been endemic to the U.S. COVID-19 is making these injustices more clear. We must come together as a medical community and change our practice. We must act. When the mortality rate from COVID-19 in Black Americans is at least 2 times, if not 5 times as high as the mortality rate for whites, we must act. When marked racial disparities in diabetes management exist, and prior to COVID-19, we must act. When Black Americans with diabetes with equivalent socioeconomic status as white Americans are less likely to be prescribed intensive insulin management regimens and diabetes technologies proven to improve diabetes outcomes, we must act. We must act and recognize systemic racism and implicit biases that are also occurring within our medical community and our practice. Our leadership team and faculty are committed to promoting health equity through our program and combating systemic racism in the U.S. We are committed to action. While we had expected health disparities to be a theme throughout this series, we also have an upcoming didactic session on diabetes disparities that I want to call your attention to on July 22nd. That will be presented by our faculty member, Dr. Ashby Walker, a medical sociologist and my close colleague who directs the Echo Diabetes and the Health Equity Initiatives at the University of Florida Diabetes Institute. In the meantime, on behalf of the Echo Diabetes team, I encourage you to start to act to address systemic racism and implicit biases that is occurring in our practice. Here at Stanford, we're partnering with Project Echo and other states across the U.S. on this series. Project Echo is a globally recognized hub and spoke outreach model developed at the University of New Mexico to reduce disparities and improve health outcomes in patients who otherwise lack routine specialty care. Zoom-based clinics led by multidisciplinary faculty from academic medical centers and community organizations provide providers with education, case-based learning, and expertise that they need to treat patients within their own community. Our presentation agenda will be a lecture followed by a submitted case presentation from the community, and then we'll address some of the pre-submitted questions our audience members submitted during registration. For those of you who have not participated in an Echo session, please submit any clarifying questions and or recommendations in the Q&A box during the case. Please use the Q&A feature in the Zoom to submit questions specific to the topic or presentation. The chat box can be used for communication amongst our attendees and for sharing resources and best practices. We'll try our best to address all of your questions submitted through registration and chat. However, if we're unable to do so, please register for a future session and we would like to address your question. Our web development team is working to build a resource library on our COVID-19 website where session materials will be found. After the webinar ends, you will be emailed an evaluation that will enable you to claim continuing education credit. Please note that none of our faculty have any relevant financial relationships or commercial interest to disclose. If you would like to submit a case presentation for a future webinar to discuss live, please visit our website. You can find the URL in the chat box and also here. You should have received an email confirmation after registration of each session, which also has a link to the submitted cases. We have an exciting series yet to come with excellent relevant topics. As a reminder, you and other learners are welcome to drop in for any one session, and this is a list of our upcoming sessions. We're fortunate to have a national faculty team from over 12 ECHO programs and organizations around the country. I would now like to introduce them, and I'm going to stop sharing my screen. Once again, I'm Dr. Nick Cuttress, a pediatric endocrinologist from Stanford University, and I'd like to introduce other members from the Stanford team. Linda.
Hi, I'm Linda Baer, and I'm the Director of Education for the program. I have also had type 1 diabetes for 49 years.
Marissa.
Hi, I'm Marissa. I'm the Program Manager, and I have had type 1 diabetes for 30 years, and I'm a nurse and a diabetes educator.
Christine.
Hi, I'm Christine. I'm the Program Coordinator.
Moving on to our faculty, also at Stanford, Marina.
I'm Marina Bassina, Adult Endocrinology at Stanford.
And Magdalena.
Hi, I'm Magdalena Ford. I'm a nurse practitioner with Stanford's Adult Endocrinology Clinic.
And Jessie.
Hi, I'm Jessie Wong, and I'm a diabetes psychologist at Stanford.
Also in California, Jay.
Good morning, everyone. Jay Schubert, primary care diabetologist at Touro University, California.
And moving to Florida, Eleni.
Hi, I'm Eleni Sheehan. I'm a nurse practitioner and diabetes educator at the University of Florida.
And Ashby.
Hi, everyone. I'm Dr. Ashby Walker. I'm the Director for Health Equity Initiatives at the University of Florida Diabetes Institute.
And aloha to the early morning hours over in Hawaii, Dan.
Good morning. I'm Dan Saltman. I'm a primary care internist in Honolulu.
And Erwin.
I'm Erwin Brodsky. I'm an endocrinologist at the Endocrinology and Diabetes Center at Maine Medical Center and a scientist at the Maine Medical Center Research Institute.
And to Massachusetts, Samar.
Oh, she should be on shortly. She was having some audio issues.
Okay. And to Nebraska, Leslie.
Hi, I'm Leslie Island. I'm an adult endocrinologist at the University of Nebraska in Omaha, and I also have type 1 diabetes.
And to New Jersey, Mary.
Hi, everyone. I'm Mary Bridgman. I'm a clinical professor at the School of Pharmacy at Rutgers University. I'm an inpatient internal medicine clinical pharmacist at Robert Wood Johnson University Hospital, and I'm representing our Robert Wood Johnson Medical School Complex Endo Echo Hub team today.
Great. And to New Mexico at the Echo Institute, Matt.
Hi, Matt Bichonville. I'm an adult endocrinologist at the University of New Mexico.
And New York, Marissa.
Hi, I'm Marissa Desimone. I'm an adult endocrinologist at SUNY Upstate in Syracuse, New York.
And to Washington, D.C., Nicole.
Hello, yes, my name is Nicole Earhart. I'm an adult endocrinologist at George Washington University and the lead on the GW Diabetes Echo.
Washington, D.C.
Hi, everyone. I'm Rohit Jain. I'm an adult endocrinologist, also at George Washington University in Washington, D.C.
And now it's my pleasure. Oh, it looks like we also
Wait,
have
one more panelist.
Great. And then Kelly, you want to introduce yourself?
Good morning. My name is Kelly Close, and I'm here representing patients. I've had diabetes for almost 35 years, and I'm editor-in-chief of diatribe.org.
Great. And now it's my pleasure to introduce our speaker for today's lecture, Dr. Jennifer Sherr from Yale University. It's such a pleasure to have you here and sharing your expertise with us. As a reminder to the audience, as Dr. Sherr is presenting, if you have questions, feel free to type them into the Q&A box, and our faculty will respond at the end of her talk. We will open up for additional Q&A. Thanks again, Jen.
Well, thank you so much, Nick. I'm really excited to be here with everybody today, and I appreciate the invitation to present on this topic, and also for everybody joining the call and being interested in learning more. So bear with me as I get used to the computer. These are my financial disclosures, but I think the most important disclosure that I have is one that many on the call share, and that's that I've been living with type 1 diabetes since 1987. And so feel like this is very near and dear to my heart. The learning objectives for today are that by the end of the presentation, you'll be able to identify software available to your practice to remotely monitor patients, to describe benefits of having remote monitoring available, and to discuss practical implementations of this in your practice. So before we begin, I know Nick did a great job of just describing the grim state we are in terms of diabetes care. And I just wanted to reiterate that with this data from the Type 1 Diabetes Exchange. And this was published in 2019. And the Type 1 Diabetes Exchange, for those who are not aware, is a consortium of over 75 centers. And this data focuses on patients who are in the registry at both time points listed, the 2010 to 2012 cohort in red, and the 2016 to 2018 cohort in blue. And what you'll see here is ages on our x-axis, and on our y-axis, we're seeing mean A1C. And with the goal A1C levels indicated by the dashed line, it's evident that we're not meeting targets in terms of mean A1C across the age spectrum. And, you know, highlighting this even more, we know that there's this grim picture being painted, but it's also critical to understand that there's been a turn in the tide to shift beyond A1C. And, you know, the group at Diatribe has done a wonderful job of really spearheading this. But I love this quote from Dr. Bob Ratner, who's a former ADA Chief Scientific and Medical Officer. And he stated, from a patient standpoint, A1C doesn't tell you how to make it better. It just says something's wrong. And we need to have the tools to get to a desired A1C. I also love this quote that I stole from on the Diatribe site, saying, behind every A1C, there are so many moments, real life struggles and triumphs. Don't take these for granted. We're people first. And so there's been an appropriate shift to talk about more clinically meaningful outcomes like time and range. And I know this was reviewed somewhat last week by Dr. Oser, but I think it's important to understand the concept of time and range. So a few years ago, major diabetes organizations, including patient advocate groups, came out and explained that we should be focusing on these clinically meaningful outcomes. And one of these primary outcomes is time and range. And time and range is defined as time spent between 70 and 180. And in the typical graphics that we see, it's going to be represented in green. It's also important to note time spent in hypoglycemia, which can be defined as less than 70 or less than 54, and represented in graphs typically in red. And finally, also highlighting the time people are spending in hyperglycemia, time over 180 or over 250, which can be represented here in yellow. And so the big thing to note is that in addition to the importance of understanding these metrics, there's a lot of information to indicate that time and range directly correlates to patients' quality of life. And so I think it's really important to use this as we guide our decisions and come up with therapeutic path forward with our patients. Last year, there was a publication that highlighted consensus on what we should seek to achieve with time and range targets. And if we focus on this first box, it's indicating those with both type 1 and type 2 diabetes. And what you'll see here is that consensus guidelines recommend that we seek 70% time in that target range. And clearly we want to minimize time hypo, so less than 4% under 70 and less than 1% under 54. But I also think it's really going to be critical to understand that we need to meet patients where they're at. And so highlighting the fact that every 5% increase in time in range is associated with clinically significant benefits. And just to put it in context, a 5% increase in time in range means that somebody is spending an hour more a day in target range. And that feels so much different. And so I think we can all understand that A1C may only partly tell the story. And this is really beautifully indicated by this graphic from Diatribe. And what it's showing is that there's many faces of a 7% A1C. So we may be thinking, okay, we need to hit that target of 7%, which would equate to an average blood glucose of 154. And if we think about how that might correlate with time and range, in our minds, we may be saying, okay, well, this person's probably reaching those consensus guidelines. They're spending 70% time and range. But in actuality, somebody with a 7% A1C could be either experiencing frequent ups and downs, as indicated on the graph on the left-hand side of the screen, or maybe they're in range all the time. And so how we would go ahead and treat these patients is going to be vastly different. But the only way we're going to know what to do is by utilizing remote monitoring software to allow us to access their diabetes data. So how can we ensure we can access our patients' data? So I always think about when I was a kid and I went in with my logbook and it was filled in, and I hoped it provided a good picture for my endocrinologist. But in many ways, I think logbooks are like paint by number. There's no depth to the picture. And so the software that we're going to use instead to download diabetes devices is going to present a much more rich picture so that we can come up with a better way forward in terms of our management decisions. And it's important to understand that there's lots of different platforms out there. Many of them are proprietary, so CareLink will work for a Medtronic pump and sensor. Clarity we can use for Dexcom. For the Insulet Omnipod pump, we can use either Glooko or Tidepool. Libre has LibreView. T-Connect is used for the T-Slim pump. But in many ways, I think the best thing to utilize is something that is more device agnostic. And so that's what I want to concentrate on today. So we're going to talk about both Glooko and Tidepool, as they'll allow for integration of a multitude of devices on these platforms. So who do these platforms serve? I think central amongst the individuals served is obviously the person with diabetes. So they can go ahead and access their data. But in addition to that, these software platforms can also be used by providers and clinics, as well as even researchers. And what sort of data can we gather from these platforms? We can get data from blood glucose meters, continuous glucose monitors, smart pens, and insulin pumps. Patients can also log information into these systems. So I have some patients who will say, I changed my site at this point, or I had ketones here, so that they can help direct me in terms of what's happening with their overall care. So I think the major point here is, regardless of the insulin delivery modality used or the glucose monitoring technique, these platforms offer the opportunity for rich data sets. So before we delve into the specifics of these two platforms, I want to discuss briefly the benefits of remote monitoring. One of the first is the efficiency in clinic at home. So really, we're going to go to one system to allow uploading of all the devices. We only have to learn that one platform instead of having multiple sites that we have to go to and get the data onto. The data is integrated into one report. So if I am seeing a patient who is using a Medtronic pump but a Dexcom sensor, I can't put everything together unless I'm using these integrated platforms that'll allow me to see the full picture of what's going on. These platforms are HIPAA compliant, so they protect patient data both during the upload and continue to protect the data once it's stored. They're FDA registered or cleared. And there's business associate agreements. And what this means is that they're already prepared in terms of contract negotiation, how to go ahead and partner with clinics to go ahead and initiate use of these platforms. But I think the most important benefit is it really allows us to engage our patients with their data to set individualized treatment plans. So I'm going to briefly go over Glooko and Tidepool, and I'm doing this in alphabetical order. So Glooko provides software in the form of a unified diabetes management platform. It's been designed for both providers and patients. It's compatible with the vast majority of meters, pumps, and sensors. And patients can add notes to their data, and they can also go ahead and sync up both their fitness and biometric data to allow for a more rich presentation. In terms of the types of accounts that are available, it's important to note that during the pandemic, Glooko has said that they will offer free access to their service, but usually it's specified into 3 buckets. So the first bucket we're going to see is for the individual with type 1 diabetes, and this account is created free of charge. The next bucket we'll see is for those who are using Glooko in research endeavors. The one I think we want to concentrate on today is Glooko Enterprise, which is the type that would be used in a clinical setting. And it's important to understand that Glooko Enterprise has some additional add-on options. And these include that if you're using Glooko and you are in your electronic medical record, you can click and it'll directly link you to Glooko so you can see your patient's data. In addition to that, PDFs of the reports can be automatically attached to the electronic medical record once it's synced with Clinic. And there's also the ability to extract data into flow sheets to be used in your electronic medical record. But again, all of these are add-ons to that basic service to go ahead and use this system. Transitioning to Tidepool, Tidepool is a nonprofit organization that's dedicated to making diabetes data more accessible, actionable, and meaningful for people with diabetes, their care teams, and researchers. So I think it's important to note that they believe that connected data leads to better decision-making. I think we would all agree with that. And their statement is that its software liberates data from diabetes devices and places it in the context of the real world with the ability to easily share the data with others. Just like Glooko, it'll integrate meters, sensors, pumps, and pens. And they really highlight that it's a very personal endeavor. I love this statement that they have pancreas in the game. And due to the fact that many of them are living with type 1 or caring for individuals with type 1, they really seek to try and get things right in terms of how they allow access to data or provide that bridge to the data that's available. But most important, I think, is that thanks to the No Clinics Left Behind grant from the Juvenile Diabetes Research Foundation, Tidepool is free for clinicians and all end users. So in all honesty, the free part really caught the attention of Yale. And while we had been downloading for quite some time, I'd like to share with you my own personal perspective of integration of a particular platform into our clinical practice. So for many years, our practice had been to go ahead and use device proprietary software, but it wasn't providing a complete picture. And also patients may change devices and then you're going to have different reports to look at. And so we really felt like we wanted to provide consistent education and empower patients to be able to view their data and understand how to make changes. And so we started in February of 2019 trying to get Tidepool integrated into our clinic. And this really was initiated through meeting with the quality team at Yale and discussing the potential benefits to implementation of Tidepool. So I think it's important to highlight some of the critical components that helped me to get this done. And one of the biggest is obviously internal IT support. So, you know, having the team in IT helping us and getting their buy-in was critical. We had a pioneer who just took this on and said, okay, I'm going to work with you throughout this to help make this a smooth transition. But also because of the fact that when you're viewing data on Tidepool, you need to be using Google Chrome, it was really important to have IT there and available to help us get that installed on all our clinic computers. Contracts. So with any type of agreement, you know, it's going to have to go through negotiations. But in our experience, because there's business associate agreements already available, it definitely goes smoother and we're able to expeditiously go ahead and execute contracts to begin using the product in our clinic. And then I think it's really critical to always think about who's going to be using the platform in your clinic. So prior to implementation, I sent out some information to all of the care providers, including MAs who would download and physicians and providers who would be looking at the data and reviewing reports, and asked for feedback so that we could make sure we were making the correct adjustment over to this new downloading platform. In terms of preparing for integration into the clinic, we went ahead and in June of last year began to have webinars with a team from Tidepool. So all our staff members were asked to join on these sessions, and Tidepool was wonderful in terms of setting this up with us. And the sessions reviewed uploading and reading reports. So there was a lot in every single session that we went over with them. Looking back on everything, I think we could have done this better and really concentrated on different tasks and allow for shorter sessions. So, you know, maybe a session on how to enroll someone in clinic, a session on how to help somebody set up a personal account for patients, a specific session on how to upload devices, and then a different session on how to view reports. I would suggest everybody should be part of all of these sessions, but maybe doing smaller snippets would really help. One of the things that has since occurred is that Tidepool has now created some videos that are available on demand that walk you through some of these procedures. So if your providers can't go ahead and join a webinar at a certain time, you can go ahead and send them links so they can see how to go ahead and get this started. So to set up a personal account, someone with diabetes or their loved one creates a username and password. And if the individual is less than 18, in the case of my practice where I see pediatric patients, they need to have their parent register for the account and then indicate that they're uploading for somebody who they love who has diabetes. And then they can input the person with diabetes birthday. And then they download the Tidepool Uploader. And the nice thing is there are very clear resource guides that go over exactly how to get all this functionality started. And then in order to upload the devices, people can literally click on the device that they want to go ahead and upload, and it'll give you step-by-step instructions on how to get it done. So how did our launch in clinic go? So we went live with Tidepool in July of 2019, and we really were prepared for growing pains in the first 6 months, primarily due to the fact that every single time a patient came in, we had to go ahead and create a new Tidepool account. And so we knew that process was going to take a little bit longer. And whenever you adopt something new, I think it's important to recognize there's growing pains. And so some of the ways that we came about this, we have a number of satellite clinics. So at each clinic location, we identified one point person who would serve as a champion. And so if troubleshooting issues came up, that person was ready and available to assist. We also kept binders of written materials so that this way we could go ahead and look things up and be prepared to go through any issues. And I have to say, again, we were able to ask IT to come in and staff some of those early clinics just to see if we were having any issues in terms of getting everything to work. Another important thing that we learned was recording the email that was used for signing up to a Tidepool account in our medical record. And the reason for that is because you want patients to go home and create a home account. And ideally, it's going to link to the email that you've already used. So now the data is going to be shared between the two of you. So how has this transformed care in the era of COVID-19? So in March, like all of us, we had to quickly pivot to telehealth. I had always wanted to do telehealth, but there had been a number of barriers, and all of a sudden, we're ready to go. But I think having the ability to access patient data from their devices allowed us to continue to provide very fruitful discussions for our telehealth visits. What we recognized, though, was that the vast majority of our patients, although they had already been enrolled into Tidepool and Clinic, many hadn't created a home account. And so the struggle we went through was getting people through the process of now creating their home account. And so some ways that you can ease the burden of this, with many electronic medical records, you can send messages to patients. We sent step-by-step instructions a week prior to any clinic visit, instructing them how to go ahead and enroll. And by having the email that they use to link the account in clinic, we could easily tell them, use this to sign up for your account, so we'll be linked. We also follow up with phone calls. And if patients need greater support in terms of how to get everything set up, Tidepool has offered their support line to be able to assist people through the process, and that's been very helpful. Again, trying to unburden our staff so they can do other tasks and have somebody else help patients get to downloading their diabetes devices. I think one of the biggest things we came across was ensuring that patients have the necessary cables for device uploads. So, asking as you're seeing them, do you have everything you need, or making sure that they go ahead and get them from the companies so that it'll allow for the upload to occur. So I think it's so great to have the ability, excuse me, to remotely monitor the data, but I think the proof is really in the pudding. And so in this case, it's really seeing what the reports can provide and why I think it really does help in terms of our management of our patients. So I wanted to just walk you through some of the reports that we use in our clinical practice. So this is where I typically start. We're seeing the basics for a pump user not on CGM. And it's very easy with a quick glance to see that this individual is using blood glucose meter data in this particular upload. And then right underneath that, I can see their time in range based off their blood glucose meter data and their average glucose. Directly underneath that, I can see their total daily dose, their breakdown of basal and bolus insulin, and their carbs that they're entering per day. And then over on this side, what we're seeing is the blood sugar reading. So how many times a day are those blood sugar readings being entered into the pump? I always find it interesting, on this particular report, we have some instances where there's only a single blood sugar entered. And having that visually available really allows for some conversation. What happened that day? Was the blood sugar good? Did you decide not to enter it? And allows us to go in places that we may not have been aware of before. And underneath that, we can see bolusing that's occurring. And the feature that I like here is that it shows me overrides and underrides in terms of whether or not somebody's going above or beyond what the bolus calculator recommends. And it's been helpful because in some situations, people on a sensor will say, well, my sensor was trending up, so I needed to give more insulin. Excellent, then I know that you have that concept down. In other cases, it allows for a conversation of, in this situation, somebody who's overriding constantly. Maybe they feel like their correction factor or carb ratio is off, but they haven't shared that with you. So it allows you to broach that conversation and, again, individualize therapy. Lower down on that same sheet, you can see the frequency of infusion set changes. And that's been helpful because if somebody's wearing a site for 5 or 6 days, we can talk about, strategies to go ahead and remember to change more often. And then further below, we can see the basal rates that are indicated. I find this interesting. Some parents frequently use temporary basal rates to the point where I've seen this be somewhere in the 300 range. And it's not through automated insulin delivery, it's through what the parent's doing. And so it allows me the moment to say, let me help you to try and tweak things so you don't have to do all of this work. I did want to point out that on this particular page, if somebody is using a T-Slim Control IQ system, which is going to go ahead and automate insulin delivery based on sensor glucose values, you can see it's captured in these Tidepool reports as temporary basal rates, because there's no way anybody's going to be setting 2,246 temporary basal rates. So it just allows you to understand why that's happening. Now I'm going to move over to the trend analysis. And again, I think there's so much data so quickly viewable here. And this is something where I want the patient to be looking with me. Even in telehealth visits, I'll ask them to pull up a Tidepool report and look at the screen, and I walk them through everything. So again, I can see here we're looking at CGM data. I can see their time and target range, their average glucose, and their sensor usage. I even get a glucose management indicator. And the glucose management indicator is a estimate of estimate of an A1C derived from the average sensor glucose value. So in this COVID time when I can't get an A1C, it provides the equivalent to that. In my view, the time and range is much more important. However, some insurance companies really hold on to A1C, so I can list I have a GMI and have that available for documentation purposes. Then on this graph, what we're seeing is midnight to midnight with the past 2 weeks of data highlighted. And we can see the average sensor glucose and the standard variability that this person's having. So with a quick look at this particular report, I see that this individual has an average sensor glucose of 170, they're 61% time in range. As a pediatric patient, that's excellent. But if I take a look at the graph, I see that they're running higher overnight. And so it allows me to focus the conversation in clinic quickly and get to what I need to for that individual. This is the same sort of report, again, looking with blood glucose meter data. So here we can see that it's showing the blood glucose meter data instead of sensor data. Our time in range and our average blood glucose is indicated here. And the lines here represent the average blood glucose during that time period, with the individual dots representing the individual tests. What I like more than this particular graphic, if somebody is using a blood glucose meter, is the daily log, which allows me to see days on the left-hand side and time across the top. And I'm able to quickly spot using those same colors used earlier. So here, green is time and target range, red is time low, purple is high. So I can quickly see that this patient is running above target, and I can go ahead and think of ways to go ahead and tweak basal rates or assess for hypertrophy. So it can very quickly guide my clinical decisions. I can also take a look at daily views. On this particular one, it's conventional pump therapy without a sensor. I can see the blood glucose that's entered, when they enter carbs, times that there's boluses, and if there's no yellow circle above it, I know it's a correction bolus or a manual bolus that the patient gave. And then I can see temporary basal rates that the individual sets. So in this instance, I found out that the individual was setting temporary basal rates every single night, and I could go ahead and adjust their preset rates to respond to their needs. And finally, it also has all the pump settings listed in a device settings tab. What about integration into the EMR? So with Tidepool, there's no direct integration, but there is a copy as text feature. So if you hit the box, it'll allow you to import. But to me, a picture is worth 1,000 words. And so oftentimes what I'll do is take screenshots and paste them into my EMR. It also lets my patients see sort of where things have been and where we'd like to go. Our staff also goes ahead and attaches the PDF of the file to the EMR at the end of the clinic day. I wanted to briefly mention Dexcom Clarity, which is the platform to assess Dexcom data. And the benefit of Clarity is that if someone is using a Dexcom with their mobile phone as the receiver, they can create a Dexcom Clarity account, and they don't need to upload data, and they can just go ahead and share a code that's going to allow you to access all the information. So on their reports, what you're going to see is, again, that glucose management indicator on the overview report. But the report I truly love is the ambulatory glucose profile. Again, it's showing all the information I saw previously: average glucose, time and ranges, glycemic variability, percent sensor wear. And then down below, for the period that's being looked at, midnight to midnight In this case, 2 weeks of data overlapped on top of each other with time and target range shaded in gray. And so with this individual, I also was able to look at the individual days going into this and understand that they had an extreme fear of lows, so that I could go ahead and talk about this and come up with a plan to try to work together to overcome it. It's also interesting that Dexcom has weekly notifications. These notifications are push notifications that can go to somebody's phone or to email as a summary. And this is sort of what it looks like. I love the one at the bottom here. So last week, your glucose readings were in range 65% of the time. That's an increase of 2%. And the benefit is, I think it's like having a personal trainer for diabetes. It's helping you understand where you're going and keeping you on track. So in terms of final thoughts, I think that platforms that allow for remote monitoring of data allow for greater depth of our clinical visits. Use of these platforms greatly improves telehealth visits, but I think as we transition back to face-to-face, if we can really encourage patients to upload prior to coming to clinic, which is definitely our goal here, it's going to improve our workflow process. And time and range can be calculated from both the blood glucose meter and a continuous glucose meter, and those reports are readily available, so we can help our patients read the reports and understand. And goals for time and range may be more tangible to our patients than A1C recommendations we give. And we can highlight that every 5% increase in time and range is a triumph. And so really tangible goals can be set. And most importantly, if we review how to read the reports with patients, we can empower them to feel confident in analyzing their own data, and then potentially figuring out ways that they can go ahead and tweak insulin regimens. So I think we all know medicine is an art, and I'm no artist, and even a stick figure is hard for me to do. But my uncle happens to be a portrait artist, and this is a portrait he did in the National Portrait Gallery of Colin Powell. And it astonishes me how he can capture what approximates photographic detail with any person he's working with. But what was most notable, I happened to be there when this painting was unveiled, and you can see how Colin Powell is just thankful that he's being seen and being represented. And I think that reviewing our patients' data lets us see them, helps us understand the issues that are there, and allows us to jointly develop a plan. Thank you so much for your time, and I'm happy to answer any questions you may have.
Jen, thank you so much for sharing that, a great talk with us. You can feel free to stop sharing your screen now. And we're going to open up for questions. So if you want to go to the Q&A box, please type a question for Dr. Sherr. And then there are some questions that have been coming in. And maybe Leslie, you want to perhaps maybe summarize. There's some great questions about the Libre view, and maybe if people can't upload, what to do.
Yeah, so Vicki in Missouri had some great questions, and I'm going through this too with my patients in rural Nebraska and Iowa. And so a lot of my patients don't have smartphones, or they don't have a smartphone that for whatever reason is capable of showing their Libre data. So they're using their receiver because it's easy to do. And if they have their cord from the receiver and have a personal computer, great, we can walk them through uploading that data from the receiver. But sometimes that's a barrier too, and they may not have a personal computer or the technology that's capable of downloading that receiver data. So if they're with you in clinic, I think most clinics can pretty easily get the capability to download the Libre receiver data in clinic. Even my telemedicine locations in rural Nebraska have really pretty quickly uploaded that software to their clinic computer and gotten that data for me. But now when we're seeing a lot more people remotely over telemedicine, what do? You have this data in the receiver, and how do you get it? And so I've really found a lot of benefit pulling up the Libre user guide, which is just the patient user guide. And so that way, if you have that kind of right next to you, you can tell the patient exactly what button you want them to push, what the menu is going to look like, and you can tell them what reports you want to pull. So you can look at time and target, and you can adjust if it's 7, 14, 13, 30, or maybe 90 days. I usually do the 14 days so they can read out to you what their time and target is. They can read out to you average glucose, and the average glucose tab is actually broken down in 4 different 6-hour time points, which I think can be really helpful. Even if they're crashing overnight and then rising as the day goes on, that still allows really pertinent insulin adjustments. The other one I like, I think it's called Daily Patterns, which is still that weighted graph. And so sometimes I even have them flip the receiver over and shove it right in front of the camera and show me the graph. And I really feel like that's a way of getting valuable data. And it also is a way of teaching them what the receiver can do for you and how much it can analyze. And then sometimes in the follow-up appointment, you'll find that they're actually pulling up their reports throughout that time and looking at their data because prior to that, they didn't know about it.
Thanks so much, Leslie. And there's other great questions coming in. And just a reminder, today's session was also a build off of some of our previous sessions that were recorded. Some questions coming in. Can you bill for CGM interpretation review? Absolutely, yes. We'll share there's listings of those codes in previous talks, and we'll type that into the chat box. Questions if this can be used. Tidepool can be used internationally. Yes, but it is Chrome browser dependent. And then also in terms of rule settings, questions about utility of uploading data, and there may or may not be barriers there. Great. And then we had several submitted questions. We're not going to be able to get to all of them today, but at least we'll try to get to one of them. And we can post the rest and come back to it next week. So the first one was what platforms available ambulatory to pharmacists to help patients manage their diabetes, and are there any remote billing codes pharmacists can use? Mary, I'll let you take it away.
Yeah, absolutely. So I am an inpatient pharmacist. So I actually had to pool my colleagues, and I really reached out to folks that I know who work in ambulatory care pharmacy practices and the FQHC setting, and even our hospital-based district clinic. And it really turns out that there isn't just any one-size-fits-all solution for outpatient ambulatory care pharmacy monitoring for diabetes, for helping our patients achieve their goals. I think Dr. Sherr did an amazing job summarizing the various integrated diabetes management platforms that are out there. I do see that there are potential opportunities to integrate this data into ambulatory care pharmacy records in the future. And I would be interested to know if there are colleagues around the country who are actually doing that. There's also medication therapy management, or MTM platforms like Outcomes MTM, which aren't specific for diabetes management, but may help identify patients who would benefit from services. I think the bottom line at this point is that many centers are really utilizing homegrown strategies for capturing outcomes, or may have some EHR specific platforms that are in use. And I just wanted to spend a moment just mentioning billing codes. So if we can go to the next slide. With regards to billing codes and services payable, keep in mind that pharmacists are not recognized as Medicare Part B providers, except with regards to provision of immunization services. And according to CMS, billing can really only occur incident to if requirements are met. This can still be happening during the time of COVID. Our FQHCs are continuing to do this for telemedicine encounters now as well. So again, that's the incident to CPT codes. There are also billing options available through the chronic care management and through the Medicare Diabetes Prevention Program expanded model services. So I did include two different links, one to the ASHP resources for how to go about proceeding and billing this way, and also to the CMS telehealth codes that are currently in play.
Thank you so much, Mary.